Hello, I had a request for this one. So this presentation is on arterial blood gases. So let's get started. So arterial blood gases here in the office and online with students is a sore spot for a lot of students. So today's lesson is one that you might need. So there are 4 different types of acid-base imbalances. There's respiratory acidosis, there's metabolic acidosis, there's respiratory alkalosis, and there's metabolic alkalosis. So now I do have notes in front of me, so I may look down and make sure I'm telling you things right. So things to know about acid-base imbalance before we even get started. Hydrogen determines the pH. And the scale for the pH is from 1 to 14, and 7 is where they consider normal. The pH of the blood, hear me, blood, not urine or anything else, blood is 7.35 to 7.45. There are 4 systems that try to compensate the changes in the pH. We have buffers, and under buffers, we have the hemoglobin system, and it's all about the chloride shift. Each chloride ion that leaves an RBC, bicarb enters. And for each chloride that enters the RBC, bicarb leaves. Then we have plasma. They attract or release hydrogen ions, and depending on which one they're doing, will help with compensate. And then we have the carbonic acid, and that is actually the lungs. It has a 20-to-1 with 20 bicarb and 1 carbonic acid, and it's controlled by the excretion of CO2. And the rate and the depth of respirations are affected. That's how the respiratory system compensates a metabolic acid-base imbalance, because lungs or respiratory is what compensates for metabolic, and metabolic compensates for lungs, okay? And so now I'm going to go down to kidneys. It is all about phosphate buffering system, and it acts like bicarb. It neutralizes those excess hydrogen. So now there's one more on this slide, and that's potassium. And potassium has an exchange role that helps maintain the balance. So in acidosis, hydrogen goes into the cells and potassium comes out. That gives me hyperkalemia or high potassium. So any acidosis, I'm going to see high potassium. Alkalosis, on the other hand, the hydrogen goes out of the cell and the potassium goes in. So with that, I have hyperkalemia. So understanding that the buffers in the lungs are the fastest at compensating, but they don't always get it done. The kidneys are slow, 2 to 3 days for them to kick in and really going, but they are most efficient, okay? So respiratory acidosis. Respiratory acidosis is caused by anything that affects the ability of the chest to rise and fall or impairs gas exchange. So let's think for a minute. Anything that would impede the chest from rising and falling would be obesity, sedation, or fractured ribs. Things that impair gas exchange would be COPD. If you ever get a question about chronic respiratory acidosis, look for COPD, because that's what that is. Signs and symptoms of this would be lethargy, dysrhythmias related to the high potassium level, confusion, warm flushed skin related to the peripheral vasodilation, dizziness, seizures, headache, hypoventilation, the rate and depth increase in attempt to exhale the acids, and then coma, and decreased blood pressure. So the labs that are affected here are potassium is elevated, the pH is below 7.35, the PaCO2 is above 35. Remember, they're switched. 45 and above is acid, 35 and below is alkalosis. And then the bicarb is normal or elevated. The treatment for respiratory acidosis is to monitor their respiratory system for distress, give them O2, put them in semi-Fowlers, encourage them to cough and deep breathe, and then give respiratory treatments as ordered, and be prepared to do an endotracheal intubation if that respiratory system is not getting it done and they're not getting enough O2. Metabolic acidosis is caused by anything that affects the loss of base, such as DKA, lactic acidosis, or starvation. Signs and symptoms would be lethargy, dysrhythmias related to the hyperkalemia, confusion, cold, clammy skin, dizziness, nausea, vomiting, diarrhea, abdominal pain, headache, muscle weakness, coma, deep, rapid respirations, also known as Kussbaum. Don't get them confused. A lot of students in the office and online are telling me deep, slow respirations. It's deep, rapid, and decreased blood pressure. The labs that are affected, potassium is elevated, pH is lower than 7.35, the PaCO2 is normal or low, and the bicarb would be below 22. The treatment is to monitor for respiratory distress, monitor their I&O, be ready to give IV fluids as ordered to increase the base, initiate seizure precautions, and then of course for DKA, which is the diabetic ketoacidosis, you would give insulin and fluids. Those are your two priorities. Respiratory alkalosis is caused by any condition that causes fear or panic. Examples would be anxiety or a panic attack. A lot of questions about this have that in there. Hyperventilation and pulmonary emboli. All of those invoke panic. So signs and symptoms, they'd be dizzy, they'd have dysrhythmias, lightheaded, nausea, vomiting, diarrhea, confusion, epigastric pain, headache, tetany, numbness, tingling of the extremities, low blood pressure, hyperreflexia, tachycardia, and hyperventilation. Now, let's back up for a second. If I know that they are in respiratory alkalosis and they're in a panic attack, how many of the symptoms, signs and symptoms on this slide can you not come up with when you think panic attack? I can come up with all of them, or at least most of them, because I've been through a panic attack or I've seen somebody else go through a panic attack. So if you know that metabolic or respiratory alkalosis is caused by panic or fear, it's easy to get these signs and symptoms. Then the labs that are affected, the potassium is low, the pH is above 7.45, the PaCO2 is below 35, and the bicarb is normal or decreased. The treatment is to monitor the respiratory system for distress, provide emotional support, encourage deep breathing, and a lot of us use the brown paper bag because if they're panicked, that's one way we can help them, and provide carbonate gluconate for tetany as prescribed. Then we have metabolic alkalosis. It's caused by GI losses and urine loss or intake of sodium bicarbonate. So the examples of causes for it would be diuretics, excessive vomiting or GI suctioning, and hyperaldosteronism. So signs and symptoms would be lethargy, anorexia, irritability, nausea, vomiting, confusion, tetany, headache, tremors, low blood pressure, tingling of the extremities, tachycardia, seizures, dysrhythmias, respirations, rate and depth decrease, and they go into the hypoventilation. Again, if you know it's from the loss, GI loss and urine loss in the intake of sodium bicarb, you can readily think of these symptoms if you follow the trail of the pathophysiology. So the labs that are affected, the potassium would be low, the pH would be greater than 7.45, the PaCO2 would be normal or increased, and the bicarb would be above 26. Treatment, you would monitor for respiratory distress, you would prepare to give meds and fluids to promote excretion of the bicarb, and you would give potassium as ordered. Now, usually students will say, that's good, thank you, Rhoda, but I need more help. I am not going to step on anybody else's toes. There is a YouTube video here on YouTube. It's ABG Tic-Tac-Toe, and they use survivenursing.com for ABG's practice. That is the video I use with my students all the time. The guy walks you through exactly how to diagnose an ABG. So I refer you there if you need help on learning how to do ABGs. If you need any further advice or information, you know where to reach me. Bye-bye.